Good evening and welcome to Dietary Management of IBD, a conversation about experience, facts, and common sense presented by the Northwest Chapter of the Crohn's and Colitis Foundation of America. My name is Kathleen Newbold and I am the Regional Education and Support Manager for CCFA Northwest. Before we get started, I'd like to share a little bit about CCFA and what we do here. Our mission is to cure Crohn's disease and ulcerative colitis, and to improve the quality of life of children and adults affected by these diseases. CCFA works to achieve the two parts of this mission through funding research and education and support programs to help people living with Crohn's and colitis. CCFA is the leading supporter and funder of medical research in Crohn's disease and ulcerative colitis, funding the best IBD research anywhere in the world and implementing a peer review process that ensures that only the most promising and relevant grant applications are funded. With more than 1,000 grants awarded and a total of over $169 million invested, CCFA has played a role in every major scientific breakthrough in IBD, from generating data that led to new therapies to the discovery of the first gene for Crohn's disease. CCFA holds in-person education programs throughout the country. These events provide an opportunity for patients to ask providers questions and meet others going through similar experiences. Local healthcare providers speak on topics such as treatment options, nutrition, coping, and pediatric issues. CCFA holds live webcasts featuring expert providers and researchers in the field of IBD, then posts replays at ccfa.org/resources/webcasts. Upcoming programs include Managing Costs of IBD Care and Got Bugs, How Microbiome Research is Impacting the Future of IBD later this month. Professional education ensures that providers can provide their patients with the best practices in IBD care. CCFA holds volunteer-driven support groups held monthly in communities around the country for people with IBD and their families. For group locations and meeting times, as well as guidelines for starting a new support group, please see ccfa.org. Our Power of Two program matches those seeking support with volunteers who have gone through similar experiences with IBD, either as a patient or as a caregiver. The two speak on the phone or by email. Our free online community provides a venue where you can participate in discussion boards, read personal stories, ask a question to our panel of experts, and much more at ccfacommunity.org. Camp Oasis is a special program for kids and teens ages 7 to 18 living with Crohn's or colitis. There are 12 camps around the U.S. The Northwest location is on the Olympic Peninsula in Washington. Camp Oasis is a safe place where they can feel normal with their peers and have the chance to try things they've never done. Volunteer counselors and 24/7 medical staff make this week possible. Applications for campers and volunteers will be available online in late January. These education and support programs and the critical research being conducted are funded in part by our fundraising programs. Take Steps is an inclusive event bringing together patients, family and friends, and healthcare providers with a shared goal to find a cure for Crohn's disease and ulcerative colitis. Participants raise funds and awareness in the months leading up to the event to help make an impact in the fight against inflammatory bowel diseases. On the day of the walk, participants will gather together for festivities, food, and a 2 to 3 mile walk. An estimated 1 in every 200 American adults and children is affected with Crohn's and colitis, and there are probably more people in your life that are connected to these diseases than you realize. Join us for Take Steps and help us spread more knowledge and awareness and raise crucial funds for a cure. After attending this webinar tonight, we hope you feel empowered and inspired to act. Take Steps is a perfect next step to get involved. Team Challenge is an endurance training program that provides professional coaching and a supportive team to help you train for a 13-mile half marathon while you fundraise for cures to Crohn's and colitis. In 2014, our Northwest teams will be going to Napa, California, Kona, Hawaii, and Las Vegas, and more for half marathons. See ccteamchallenge.org for more information. And as I'm sure many of you know, December 1st to the 7th is Crohn's and Colitis Awareness Week. So thank you to everyone who's been helping to spread the word to friends, family, and media to bring attention to these debilitating diseases and let people know they are not alone. Check out the action on social media with CCFA Awareness Week. It's hashtag CCFA Awareness Week. For more information on any of the programs I mentioned, please see our website, which is ccfa.org. For the Northwest chapter, it's /chapters/Northwest. So here's a quick look at who we've got on the call tonight. I hope this will make it feel a little less anonymous, even though we can't see each other. So in our residents, we've got 238 people have signed up for this tonight, majority in Washington and in our Northwest chapter states. Also a good number from California and kind of a mix from other states around the country. We've got some East Coasters. Thanks for staying up with us tonight. 112, about half of you have never attended one of our programs before. We've got a lot of patients here tonight, a lot of friends and family. And we've got some newly diagnosed folks, a lot of people in between who've been patients for a few years, and quite a few veterans, 10 plus years. So if you have a question during the program, please type it into the question box on your control panel on the right side of your screen. Once our speakers have finished their presentation, Dr. Lord will read the questions out loud, and one of the three doctors will answer for everyone to hear. During the presentation, we may ask for feedback. So on your control panel, everybody take a look at your control panel. You see a little hand. Go ahead and click this to raise your virtual hand. So please try that now. Great, great. Thank you so much. So now our presenters may also ask for participation through a poll. So we're going to try a test one now. Just so you know what to do. So go ahead and click launch. Go ahead and click your answer here. So poll is open. Just click your response. We will also be recording this presentation, and it'll be available for replay afterwards. I'll send the link to all registrants once it's ready. Great. Thank you, everybody, for answering our poll. So now I would like to introduce our moderator, Dr. James Lord. Dr. Lord is a clinician scientist studying the mucosal immunology of IBD. He received his PhD in immunology from the University of Washington in 1999, followed by his MD in 2001. He is currently a gastroenterologist at Virginia Mason Medical Center in Seattle, specializing in the care of IBD patients, and runs an IBD immunology research lab at the Benaroya Research Institute. Dr. Lord is an active volunteer with CCFA Northwest, serving on the Chapter Medical Advisory Committee and the Board of Trustees. Thank you all for being here tonight, and thank you to our speakers. Dr. Lord.
Thank you very much. Kathleen, I think that the screens are reversed here. The audience view appears to be reflecting the monitor screen as opposed to the screen on your computer. So I apologize to everyone. It looks like you're seeing all of our slides as they're coming out here. I'm not sure how we actually alter that. But Kathleen may be working on that in the background. But anyway, good evening and welcome to our talk tonight. I'm Dr. Lord, James Lord. I'm a gastroenterologist at Virginia Mason Medical Center in Seattle, and I also work at the Benaroya Research Institute as a basic immunology researcher. Joining me tonight on my right is Trina Seligman, a naturopath in Bellevue, Washington, and also a licensed acupuncturist, and also a patient with a close personal connection to inflammatory bowel disease, having lived with ulcerative colitis and its connections now for how many years, Trina?
28 years.
28 years. And then joining us by phone is Shirley Paskey from the Veterans Affairs Hospital, who is, like myself, a gastroenterologist and also has a Master's of Science in Nutrition. And so a very qualified person to be discussing some of the issues that we're connecting tonight. Can you hear us by that phone there, Shirley?
I can, thank you.
All right. So the first question on the agenda, just to sort of launch things off, how important is inflammatory bowel disease? So it seems by common sense that because the GI tract is obviously where your diet is digested, and inflammatory bowel disease is itself a disease of the GI tract, how could diet not affect IBD? But the truth is, there's actually surprisingly little data about diet and inflammatory bowel disease. There's been epidemiologic data to suggest that perhaps diet plays a role based largely upon the fact that IBD tends to affect predominantly countries which have adapted to a Western diet, but this also includes the entire Western lifestyle with which many things covariate. So our first question is for you, Shirley. Does diet actually cause inflammatory bowel disease?
Well, that's a good question. And quite frankly, it's actually very difficult to prove. I would say at this time, we actually don't know what causes IBD, and the etiology of IBD is believed to be a complex interaction between one's own genetics with the environment, which would include diet, as well as the microbiome, which then leads to an inappropriate immune response. Next slide. When studies have been done, a lot of things have come up as possible associations, but have we found a silver bullet at this time? Not yet. Next slide, please. In some studies, people have done what's called cohort studies. So large groups of people are followed out for a long period of time. And what we have learned from adults that have been studied in this way is that there are no clear etiologies of diet in association with inflammatory bowel disease. The only associations that there have been are some weak associations with animal proteins and certain fats. However, these studies also have many limitations. Mainly, they are limited to adults only. There are many confounding factors. And perhaps most importantly, just having a correlation between animal protein and some fats and the development of inflammatory bowel disease certainly does not indicate a causation. Next slide.
So, Trina, if diet, we can't necessarily say that, wait, these are out of order. Whoops, okay. So my question actually was, no,
just go with that. Just go with that.
Okay. So, yeah, if diet, can diet cure IBD, Trina?
Well, technically speaking, there's no cure for IBD. For ulcerative colitis, a colectomy is considered curative. However, remember, this is an autoimmune disease. So therefore, there are systemic symptoms that can still be present post-colectomy, including arthralgia, oral health symptoms, even pulmonary symptoms. So it depends on how we define cure. So is it symptom improvement versus absence of disease based on pathology? So yes, today we'll discuss that we can help symptoms improve with diet, but we lack the data to say conclusively that diet can lead to an absence of disease on pathology.
And one point that I think it makes it difficult to actually consider what the meaning of cure is that how do you define permanent when a human lifespan is itself finite? I mean, if you can get 20, 30, 40 years of remission, that's really not differentiable from a cure. But even if we can't say that diet can cure IBD, surely can we assume that diet addresses the physiology of inflammatory bowel disease?
Maybe. The role of diet in altering the sort of course of IBD is certainly evolving. We do know that there is interaction between diet and many of the factors that are related to IBD, but the exact relationship between all of these is really poorly defined. So next slide, please. With the association between diet and the microbiome, this essentially is the relationship between what you eat having an impact on the bugs that are living inside your GI tract. And a relationship between that has been shown. However, we haven't shown that any specific diet alters the course of IBD. So there's, again, a missing link there. Next slide. The same thing is shown with immunity. Unlike the relationship between gluten and celiac disease, where the immunology has been actually very well defined with how gluten interacts with that. The same thing has not yet been shown in IBD. Next slide. Perhaps another interesting role for diet in altering the course of IBD is the interaction with medications. There's an emerging role for vitamin D and vitamin D status at altering the efficacy of anti-TNF therapy, and certainly that's something that we really want to explore, along with the role of diet and other medications too. Next slide. Now the caveat to all of these theories is we really don't have any convincing studies in humans with clinically significant outcomes, so there's still a lot of research to be done. Next slide.
Then, as a consequence of this lack of data, I think that a lot of practicing physicians like myself often doubt that diet is necessarily affecting the inflammation that underlies inflammatory bowel disease so much as affecting the symptoms. But can it at least reduce symptoms? And is this a valid goal, Shirley?
You know, I think it is. The importance of deep remission is currently being debated, and even though it's quite valuable, I think that controlling symptoms is very important just for someone's overall well-being as well. So we have something called the Crohn's Disease Activity Index, which we actually use for FDA approval for many of the drugs that are used to treat inflammatory bowel disease. And as you can see here, the majority of this score is actually based on GI symptoms. And certainly diet can actually affect a lot of these symptoms. Next slide.
So diet can modulate symptoms, and in my experience, and preliminary studies support this, diet can have a profound effect on symptoms. And since the CDAI is based on symptoms, this meets the gold standard as a valid therapy. In general, I find patients have a list of safe and unsafe foods that they will use during periods of disease activity, or even just try and stay healthy during periods of remission. Understanding what those foods are can empower the patient and can help them control disease activity. Obviously, depending on disease activity, it may not be appropriate for a patient to be trying to embark on diet changes. If they're bleeding or require acute management of their disease, it's not the appropriate time. And I think also it's important to remember and understand that working on diet goals does not have to be to the exclusion of using conventional medicine. Both can be looked at simultaneously.
So if cure is too lofty a goal and the physiology is unknown, can diet at least alter the clinical course of inflammatory bowel disease, Trina?
IBD is usually not fatal, and actually patients with ulcerative colitis tend to live longer than the general public because they are more frequently non-smokers.
You know, however, I think reduced morbidity is certainly a viable goal. If someone can delay or prevent surgery or hospitalizations by reducing their symptoms, then I think it would definitely be beneficial.
Also, diet can reduce disability, and disability from IBD is primarily due to the symptoms. So if diet can reduce the symptoms and can reduce disability, this is a worthwhile goal. IBD is a major source of disability, and it affects young people while they're trying to attend school and work. And lost days of school or work due to disease can have a significant impact on the quality of life. Patients may back out of social activities if symptoms are not well controlled. So using diet to decrease symptoms can empower the patient and decrease disability.
So what dietary strategies have been proposed for inflammatory bowel disease? I'm going to go over a couple of different sort of approaches to how one can use diet to control their symptoms in inflammatory bowel disease. And what I generally try to emphasize to my patients is that probably the most important thing is to just see how your diet affects your symptoms, be a scientist about it, and track what effect your diet is having. So having a good mechanism for keeping a diet and symptom diary simultaneously for trial and error is, I think, a critical part of the process. Historically, we've used pen and paper, which can be very cumbersome, but fortunately in the day of the smartphone, there are some digital approaches we'll mention later that considerably facilitated this effort. There are also specific exclusion diets. Keeping it simple, one can focus simply on a particular food group and eliminate that one group, such as dairy or lactose, wheat and gluten, or in the case of stricturing Crohn's, as Shirley will mention in a moment, insoluble fiber. Also, there are publicized diet plans that we'll go into a little more detail about, such as the specific carbohydrate diet, the Paleolithic diet or Paleo diet, and the Low Fodmap diet. So Shirley, can you talk a moment about the role of fiber in Crohn's disease?
Yeah, this is something that's been debated and actually studied in several trials. So there's a difference between structuring Crohn's disease and non-structuring Crohn's disease. So a structure in Crohn's disease is a fibrotic narrowing, not an inflammatory narrowing, but a fibrotic narrowing of the GI tract. And in people who have non-structuring Crohn's disease, there are actually no differences between those who are on a low fiber diet and those who are on a regular fiber diet in terms of their symptoms, hospitalizations, and overall sort of well-being. Now, the situation is a little bit different for those with structuring Crohn's disease. So in people who do have those fibrotic obstructions, ingesting a low insoluble fiber diet, so diet that doesn't contain things like corn husks, nuts, and seeds, this can help to reduce their risk of developing an obstruction. Next slide.
Well, curiously, high-fiber diet was once upon a time, back in the dark ages of 1987, trialed as a beneficial dietary therapy in Crohn's disease and one of the largest dietary trials ever published for IBD. However, the scientists chose to use a high-fiber diet in conjunction with a low-sugar diet, thus violating a basic principle of the scientific method that one should never alter one variable, or more than one variable at a time when trying to test a hypothesis. And so it's possible that now that we know fiber can potentially be problematic to patients with Crohn's, it may have masked some beneficial role of a low-sugar diet, raising the question of whether carbohydrates and a selective carbohydrate diet may play an important role. So if so, are sugars and carbs important modulators of inflammatory bowel disease, Shirley?
Well, you know, this is something that has been theorized, specifically with the specific carbohydrate diet or the SCD diet. So in your food, it will contain monosaccharides, disaccharides, and polysaccharides. Now, your intestines are only able to absorb monosaccharides. The disaccharides and polysaccharides need to be broken down by bacteria or enzymes in your gut in order to be absorbed. So the theory in this diet is that if you exclude the disaccharides and polysaccharides, you eliminate that sort of enzymatic requirement and you eliminate the sort of substrate that the bacteria are able to use for their fuel, and as a result you get less fermentation and gas and diarrhea. So that's the theory behind this diet. Next slide.
So Trina, what does this mean in practical terms? I mean, most people can't look at a food and necessarily know whether it has polysaccharides or monosaccharides. So what does the specific carbohydrate diet actually consist of?
Well, the specific carbohydrate diet was first described in the book Breaking the Vicious Cycle, and I often refer people back to the book, or there's a website where they can look up individual foods. But in general, the allowed foods on the list are fruits and vegetables, primarily green vegetables, and excluding things like potatoes and yams. And animal proteins and nuts are all allowed. And foods that are not included in the diet are commercial sugars and syrups. And as I said, the potatoes and yams, starchy vegetables. And it only includes very specific dairy products. In my experience, and especially if you read the book, you'll see that they suggest for people to go on the diet for a year. And I find that patients often don't get started on the diet because it's very overwhelming to to think of going on a diet for a whole year before noticing any kind of symptom relief. I generally suggest for people to plan on attempting the diet for 2 to 4 weeks. The diet's less overwhelming if you consider it for a short period like that. And also in approaching the diet, just stick to what we call more of a whole foods approach. So foods that don't require a label, like carrots and broccoli don't have a label on them. The more processed the food is, the more likely it is to contain the sugars, the disaccharides that you need to avoid. And every time you read through labels, it'll cause a lot of frustration. Over time, if you find that the diet's helpful, then start to invest more time in learning the specifics of the diet. There's a lot of recipes for the diet using almond meal and preparing your own specific type of yogurt and dairy products.
So let's break for a sec to get a little audience participation and try one of these polls here. So it should pop up in just a moment.
Yeah, the question is, I have found the SCD diet to be helpful at reducing my symptoms. And then you can just click off yes, no, or have not tried it.
Who is it?
So we're just giving everyone a moment to click in their answers. Okay, looks like the answers are starting to slow down. So let's share the results here. So actually, Shirley, we have a tiny little postage stamp screen I can't read. Can you read off what the results are?
Yeah, so actually 24% of people said yes, it's been helpful. 3% of people said no, it hasn't been helpful. The majority of people, 74%, haven't tried it.
So another diet, getting back to our presentation. Okay, looks like we're back on the slides. So another related diet that comes up periodically is what's called the Paleolithic diet or Paleo diet, which was based on the concept that humans should eat the same foods on which our hunter-gatherer ancestors evolved, and consequently, this diet emphasizes foods that can be hunted or gathered while prohibiting foods that require more complex processing or agriculture.
So the paleo diet's nearly identical to the SCD diet.
So you'll notice that a lot of the same foods that are emphasized or prohibited overlap dramatically with what we just mentioned a moment ago. These lists actually look very similar. Third diet that has received a lot of popular press is the Low Fodmap diet. Shirley, can you talk a little bit about this?
Yes, I can. This is actually receiving quite a bit of press recently, predominantly for its use in treating irritable bowel syndrome. So FODMAP stands for fermentable oligo-di-monosaccharides and polyols. And it's actually very similar to the SCD diet, but it also excludes monosaccharides, so it ends up being quite restrictive. And the idea with this is that essentially you avoid eating a lot of those fermentable carbohydrates that can lead to some of the symptoms associated with IBD. Now, I think it's also important to recognize that, some of the efficacy of this diet, and perhaps some of the others, is that there may be some overlap between irritable bowel syndrome and inflammatory bowel disease. So some of the symptoms you're treating may be related more to IBS than IBD.
Well, how do we know that what symptom improvement has actually been realized through following a FODMAP diet isn't actually due to helping IBS instead of inflammatory bowel disease?
Does it matter?
Well, I guess it's the goal of symptom control, perhaps not. But Trina, thanks for piping in, and could you give us a little more detail about what a FODMAP actually consists of and whether there are any differences between it and some of the other diets we just discussed?
So again, with the FODMAP diet, we have a list of foods to eat and to avoid. And it's very similar to the SCD diet. But the FODMAPs diet does allow for potatoes, gluten-free grains, lactose-free milk, yogurt, and hard cheeses. It also allows for sugar, which the SCD does not. One of the things that I think is really good that they've added to the FODMAPs diet, which is not part of the SCD diet, is the elimination of the polyols, all the sugar alcohols. And in my experience, these are really important to eliminate for patients with IBD. But overall, the diet is more similar to the SCD diet than it is different.
So why don't we take another poll here and see how many audience participants have tried the FODMAPs diet.
And the exact question is, I've found the FODMAPs diet to be helpful at reducing my symptoms. Yes, no, or have not tried.
Okay, so it sounds like for all the press that it's gotten in irritable bowel syndrome, FODMAPs, at least in our listening participants tonight, has not been a particularly popular diet, as it looks like only 2% of respondents said that they have received benefit from this. Interesting. So, as Trina pointed out, there are some very common themes between these three diets we've discussed and some other diets we didn't talk about tonight that are largely based upon the same concepts. In general, these diets favor eating fruits and greens, meat, fish, nuts, and seeds, while recommending avoidance of dairy products, starchy foods, both wheat products as well as starchy vegetables such as legumes and tubers, and also avoiding highly processed foods and sugars. But a challenge that can come up is if you are actually following several different diets for different reasons. For example, stricturing Crohn's disease, as Shirley mentioned a moment ago, recommending low fiber actually makes it very difficult to find a diet containing fruits, greens, and seeds and things that are likely to get stuck in a Crohn's stricture. And so if, for example, you're a vegetarian, that doesn't leave a whole lot left on your menu. So switching the subject a little bit, I'd like to talk how much evidence there is that diet can treat inflammatory bowel disease. Is the lack of data that I mentioned earlier some corporate conspiracy to promote the use of drugs and avoid pursuing a behavioral or lifestyle change as a management mechanism, Trina?
I don't really think the lack of research is due to any kind of corporate conspiracy. These would be difficult trials to run and expensive to fund. Patients frequently make a lot of mistakes when they're trying to do the diet, so it's very hard to control unless you control their food supply. So ideally, you'd have to keep patients inpatient and provide them with controlled food, which is not very feasible and, like I said, very expensive. Also, you can't do a placebo control. If people are in the fake diet group, they're going to know it.
Yeah, it's really not feasible to do certainly long-term trials that are randomized or placebo-controlled, just because it's very difficult to have exact control of what people are eating outside of sort of a metabolic lab. The other things that make it difficult to do dietary trials is just the timing of when to do them during a flare and for how long during that period of time, or outside of a flare over the long term, such as would probably be the case for Crohn's disease. And it's also very difficult to isolate specific components. It's a lot easier to, have a trial where you just add a drug, or you add a supplement, or you don't add a supplement. But as soon as you start to modulate the diet, especially in the ones that we talked about, for example, if you're reducing the fat, by default, in order to consume the same amount of calories, you'll have to increase the carbohydrate and protein content of that same diet. So it's difficult to discern which was the sort of cause or the the helpful part? Was it reducing the fat, or was it increasing the carbs and protein? And finally, diet's just very complex with a lot of confounding variables. You can have, for example, one food that's available in one form, and then you can also find the same food, but it's in a slightly modified version or processed, and that may contain different features. Next slide. The one situation where we are able to control exactly what someone is getting into them is with using enteral nutrition. And enteral nutrition is sort of liquid food mixtures. I think you've probably heard of it more as things like Ensure or Boost supplements. And these are foods that contain a mixture of protein, carbohydrates, fats, essential vitamins, and minerals. And sometimes they also contain fiber, prebiotics, or other additives. And they're typically administered either by mouth or more commonly through a tube system, a tube that goes in through the nose to the stomach called an NG tube, or a G tube or a J tube that goes from the skin into the GI tract. Next slide. When we have studied these, they've been studied predominantly for Crohn's disease, not for ulcerative colitis, and under both active conditions where there's an active flare of IBD versus in remission when things are quiescent. For the efficacy of enteral nutrition in active Crohn's disease, it does appear to be effective in adults. However, steroids are more effective when the studies have sort of been combined. Having said that, it's also difficult to interpret some of the results of the studies because there's so many differences. And generally speaking, the enteral nutrition formulas can be difficult for adults to tolerate. Conversely, in pediatrics, the results are much more promising. Enteral nutrition is actually considered to be equivalent in terms of efficacy to steroids. And enteral nutrition has also been associated with improved growth and mucosal healing compared to steroids. Now, this sounds great, but you also have to keep in mind that there's a 50% relapse within 6 months of resuming a normal diet. And in a lifelong disease, this is something that definitely needs to be taken into consideration. And also, there have not been any studies comparing enteral nutrition to other medications to induce remission, like anti-TNF agents. Next slide. Now, in the case of enteral nutrition for quiescent Crohn's disease, this has been studied in adults and has been found to be effective. Patients were given nighttime enteral nutrition and then put on a low-fat diet during the day. And over the course of 5 years, these patients actually had reduced need for surgery and for biologic therapy. And they also had reduced risk of endoscopic recurrence of their Crohn's disease. And similar results have been found for patients who achieve remission from medications. In pediatrics, these studies just simply haven't been done. And finally, there aren't any trials comparing the efficacy of enteral nutrition to other medications like immunomodulators like azathioprine or anti-TNF agents for maintaining remission in Crohn's disease. Next slide.
Still, this is fairly convincing evidence that diet plays a role in the disease process, and at least if very tightly regimented and controlled like this, it can have a beneficial effect. But this is a pretty taxing approach to dietary therapy for most patients. Is there data for more feasible and thus popular diets, Trina?
Actually, pilot studies on the SCD diet do exist. There was a study for 11 patients using the SCD diet with probiotics for a period of 6 to 10 months, and 100% of patients had subjective symptom improvement. Unfortunately, objective signs of improvement were not studied. Additionally, recently, a pilot study from here in Seattle was published, and 7 children with Crohn's disease were started on the SCD diet. After 3 months, all 7 of the patients had symptom improvement. And not only that, in this study, they monitored objective improvement, and objective changes were shown in the lab results as well. I'm not going to go over all the data. It's on the next 2 slides. But the markers of inflammation, the CRP and the calprotectin, were reduced, and the markers of nutrition and reduced bleeding were improved, including the albumin and the hematocrit. Objective evidence cannot be faked or exaggerated.
So, of course, on the other hand, this is an uncontrolled case series, and 7 patients is not a large clinical trial. So take it with a grain of salt. There is a phenomenon called regression to the mean, in which people tend to enroll in a study when they're at their worst and then will spontaneously improve. So there could be a degree of that going on. But this does represent one of the most objective pieces of evidence to have come out concerning the specific carbohydrate diet in Crohn's disease.
There is also a study on the Low Fodmap Diet, and the study was on 52 patients with Crohn's disease and 20 patients with ulcerative colitis. Again, there was no control group in this study. Up to 70% of the patients adhered to the diet. The fact that they adhered does tell us that the diet's feasible, and also that they must have been having enough symptom improvement to warrant continuing. 1 in 2 of the patients showed benefit in at least 50% of the symptoms. Primarily, when you look at these stats, the symptoms were improved in GI involvement, so decreased abdominal pain, diarrhea, and bloating. Of course, additional studies are needed. There's no data at this point in time on the Paleo diet. The Low Fodmap diet has been used primarily for IBS, and maybe our poll today shows that too. It hasn't really gotten out into the IBD group, although we presented the one small study. And I think it's important to remember, though, the lack of data is not the same as negative data. And as we said earlier, data right now is limited by the cost and perhaps lack of interest in performing the tests by studies by the drug companies, but they're very difficult to administer and costly.
So changing the subject again, I'd like to talk a little bit about what the role is of the healthcare professional in dietary counseling. Do you have any opinions on this, Trina?
Yeah, I think it's really important to remember that diet has social and emotional impacts on people. And we don't want to make diet changes just for the sake of making changes. If they aren't necessary or helpful, they should be abandoned. And we don't want to do diet changes for a prolonged period if they're not helping or necessary. It's also important for healthcare practitioners to help provide guidance and structure on how to complete these diets, and also to provide guidance and structure on how to reintroduce foods after they've been on the diets. If somebody chooses to stay on the diet for a prolonged period, then healthcare practitioners can also help to monitor the safety of the diet, primarily meaning preventing malnutrition. When working with patients, I tend to provide more of a custom diet, not just choosing SCD or FODMAPs. And perhaps a lot of people who are listening this evening wanted us to select a specific diet, but I don't think that's possible. For example, when I talk to people, I find that often they'll have some history in childhood that they can go back to, and they'll say they can report perhaps they were very colicky when they were given milk or a certain food group, or perhaps their mother had to change their formula because they became sick on a whey-based formula and had to be switched to a soy-based formula. So often they'll have some childhood history that I'll include in designing a diet for them. Or they may already be aware of foods that bother them, and we would restrict those foods as well as including that in this information that we've learned from the SCD and the FODMAP diet. But as well, a restricted diet should be planned around somebody's social activities. Before starting the diet, they should make sure to have at least 2 weeks available where they can follow it. It's really distracting and difficult to interpret the diet if they get a few days into it and have parties to attend or eat food that's not specific to the diet. And they should plan well in advance and make sure there's enough food resources in the home to be successful with the diet so that they don't lose any weight.
So let's take a moment and see if certain foods or certain avoidance diets mentioned here, such as dairy avoidance or gluten avoidance, have been beneficial for people.
So the next poll question is,
again, in terms of answering...
We're doing a poll, sorry.
I have found a gluten-free diet to be helpful in reducing my symptoms. Yes, no, or have not tried.
And let's see. Looks like 56% of people haven't tried it, 31% of people have actually found benefit from this, and 13% answered no. And let's do another poll looking at whether a dairy-free diet has been advantageous.
So the next question is, I have found a dairy-free diet to be helpful at reducing my symptoms. Yes, no, or have not tried. Please vote.
Okay, so now it looks like about 45% of respondents have found benefit, 18% have not found benefit, and 40% have not tried it. So I'm sorry, Trina, I didn't mean to interrupt you.
I thought we were doing the poll afterwards. I apologize. So again, here we're answering the question, which diet, and the poll questions, actually, that was interesting to do them before the slide, because my advice is very similar to what we're finding in the poll. And I tend to design more of a custom diet. Both the SCD diet and FODMAPs and Paleo all look at the effect of carbohydrates on bowel symptoms. And the differences are subtle. As our poll showed, many patients have found a gluten-free diet to be helpful. SCD is more restrictive than that. I would also consider elimination of dairy. All dairy products, including casein and whey. Again, our poll supports that. The elimination of polyols, all the sugar alcohols, I have found to be very important in helping patients with IBD, and that comes from the FODMAP diet. Again, the closer the diet is to a whole foods diet, the cleaner the diet is, less preservatives, additives, chemicals, I think the easier it is to interpret. After somebody's completed the diet, at some point in time, even if the symptoms are improved, a patient should attempt to reintroduce food. And I have patients reintroduce one food at a time. And a food reaction can be very quick. It can be 30 minutes after eating. I'm sure patients have either experienced this themselves or observed it in someone they know with a lactose intolerance. They can drink a glass of milk and 30 minutes later be running to the toilet. So you can have a very rapid reaction. You can also have a very delayed reaction. So you want to introduce only the one new food in over the course of a day. And you can also have a dose-related reaction. So you should try to, I suggest, eat 3 doses of the food in one day. For example, if we're going to introduce wheat, I generally have people use shredded wheat cereal. It's the only ingredient in that cereal, and they can eat that with almond milk and eat that 3 times in one day. I also have people introduce milk, cheese, and yogurt separately, and a serving size of milk would be about 6 to 8 ounces. A serving size of cheese would be kind of like a piece of string cheese, and a serving size of yogurt would be one of those individual cups of yogurt. And again, eating those 3 times in one day. Also, cow's milk proteins are different from goat milk and sheep milk. So it is possible that if somebody doesn't do well with cow's milk, they may introduce at another point in time goat or sheep milk products, and there's some really good cheeses out there in those categories, and they may be tolerated.
So it sounds like your point is kind of that scientific method I was talking about earlier. It's very important just to test one variable at a time.
Exactly. And I think that's where the clinician can be helpful in guiding the patient. Also, this GI Buddy is an app that you can look at on the CCFA website, and it can be used to help you when you're reintroducing your foods to monitor reactions. And it also can be used to monitor other lifestyle issues like sleep and stress, because they may interfere with your ability to observe these changes from your diet.
I believe it's also available on the Apple App Store and where else, Kathleen? The Android store. Sorry, I don't own an Android. So, Trina, what are some of the risks of dietary strategy? And we've heard a lot of benefits or suspected benefits with these diets, but are there any drawbacks?
Yeah, I think that we need to take care not to cause harm, so to speak. As I said, diet has a social and emotional impact. And so we need to be careful that the diet's not too radical and something that somebody can maintain comfortably. And we need to ensure that the patient's getting adequate calories and not losing weight. And if they're using a diet long term, they need to be monitored for any types of malnutrition that can be associated with the diet, or offered the appropriate kind of supplementation to compensate for the diet's deficiencies.
That's certainly true. So, in terms of looking for signs of malnutrition, these can things like growth failure or delayed puberty in kids, especially loss of lean body mass. You can get micronutrient deficiencies such as vitamins and minerals, especially if you eliminate food groups. And ultimately, if you're restricting your diet so much that you're not consuming enough calories because of being concerned over eating, this can result in other worse outcomes as well. Having said that, there can be a little bit of paradoxical benefit as well. If the diet is helpful, enables you to eat more, then your risk of malnutrition would be lower, especially if you're managing to continue eating a balanced diet. Next slide, please. So in terms of the specific risks associated with avoiding food groups, I think, one, it's important to realize that many patients with inflammatory bowel disease are actually deficient or suffering some sort of malnutrition at the time of their diagnosis. You can see in the table on the right that, things like weight loss or even specific nutrient deficiencies can be actually quite common in both conditions. When doing these diets and eliminating certain components, dairy avoidance can be associated with calcium and vitamin D deficiencies. So it's important to make appropriate substitutes. So instead of replacing the dairy beverage that you would have been consuming with something like juice, you would want to be replacing it with an appropriately fortified, something like almond milk or soy milk that's fortified with those things. Similarly, if people are eliminating fruits and vegetables, you may develop deficiencies in vitamin A, C, and selenium, so it's important to make other substitutions of different fruits and vegetables that you are able to tolerate. Similar things for cereal grains and vegetarian diets as well. More so the strict vegetarians and just the vegetarians that continue to eat dairy products and eggs. Next slide, please.
So, Trina, what are the pros and cons of dietary strategies when used as an alternative to conventional medications, pharmacology?
I guess, first of all, I wouldn't think of it as an alternative. If the patient is a great responder, that would be the case. But for the majority of patients, using it as an adjunctive therapy can be extremely helpful. One of the pros of it is that the diet doesn't require a physician prescription. It's something that patients can initiate on their own. And it gives the patient control over the symptoms. Diet can be personalized, like I said, based on personal experience of adverse reactions or past experience in childhood of adverse reactions. And then the monitoring is up to the patient based on their dietary intake and their response.
Yeah, and I think also from a monitoring standpoint, it's helpful to share the diet that you're following with your physician so that if there are any specific nutrients that need to be followed, we can test for that as well and evaluate it. Another potential pro of dietary therapy is that you do have the reduced risk of developing symptoms, specifically adverse effects of medications. So it's important to realize that drugs that inhibit the immune system may increase the risk of infection, and that it's important that you're consuming a good diet to reduce that risk. Steroids can also be associated with many adverse effects listed here, and enteral nutrition can be considered an alternative for steroids in selected patients. Next slide, please. In terms of evaluating the cost of diets, this is difficult, and especially if you're comparing it to medications. Certainly there are immediate costs to consider, and then there's also longer-term costs too. So if you're not having your disease controlled and the inflammation controlled, you definitely run the risk of more long-term complications, particularly with Crohn's disease. Another thing to consider is that with insurance, there may be caps to some people's policies, and using diet as an adjunctive and low-cost additional therapy is potentially actually desirable and maybe necessary too.
I've heard patients in my own clinic certainly propose cost and side effect concerns with medications as a rationale for wishing to try a dietary therapy to the exclusion of conventional medical therapy. Are there drawbacks to this approach?
Yeah, I think, the main drawback to this is you're potentially delaying effective therapy. And this can certainly have clinical implications. So we know that, that drugs are effective, and we know this based on a large amount of high-quality data from research studies. Specifically, if you delay long-term therapy and run in a prolonged inflammatory state in your GI tract, you run the risk of developing complications such as strictures, fistula, abscesses, lack of growth, especially in kids, and malnutrition. And long-standing inflammation over time can actually lead to precancerous changes or dysplasia in the colon as well. And the other thing that can't be ignored either is that you may actually, by delaying pharmacotherapy, actually reduce your chance of having an effective response to the therapy when you start it. Next slide, please. I think this is actually quite well demonstrated in this study. It was actually of certolizumab, one of the anti-TNF agents. You can see along the bottom here in the second column with the green and the yellow. So the green bar actually shows that for patients that were diagnosed within the last year, they had an 89% chance of experiencing a clinical response to certolizumab. Now, if you go over to the far right column, 5 years in the green category, this chance of experiencing a clinical response to certolizumab dropped to 57%. So certainly if you want to be treating people and treating them effectively, your best chance to do so is early on. Next slide, please.
So Trina, are there ways that diet, if we're not going to use it to the exclusion of medical therapy, how can it complement other treatment strategies?
Well, I think first of all, maybe we need to revise how we define success in medicine. And success does not mean diet alone without medications. Success can mean using diet to improve quality of life. For example, using diet to reduce pain and pain medications while somebody awaits surgery. That would be success. Reducing bowel movements from 10 per day to 5 per day, even though medication would be required, that still would be considered success. Success can be helping patients who are presently not responding to conventional medications. Success can be less sick days from work or the ability to attend social activities with greater confidence.
So, Shirley?
Yeah, in addition, diet I really see as sort of a complement to medical therapy. And diet can actually be helpful for a lot of the non-inflammatory symptoms in that sense. So specifically related to IBD, diet higher in calcium or lower in oxalate can reduce the risk of calcium oxalate stones in those who are at risk for that. And dietary therapy is a large part of my practice in patients who have short bowel syndrome, and as well in patients who have strictures. Diet can be helpful in reducing the symptoms related to either mechanical obstruction or small bowel bacterial overgrowth in the area proximal to the stricture. And similar to short bowel syndrome, we also use dietary therapy for managing patients with high ostomy output. In addition, I think it's also important that diet can be controlled to actually impact on the non-IBD related GI symptoms that many patients with IBD actually have. So we mentioned irritable bowel syndrome earlier. I think it's important to realize that up to 1 in 4 adults have IBS. So it's actually much more common than inflammatory bowel disease. And so there's a lot of symptom overlap, and some patients benefit from treatment of their IBS with dietary therapy. Similar results with lactose intolerance, fructose intolerance, and non-celiac gluten intolerance, as we saw in our polls.
So I'm going to conclude. We've been talking now for about an hour, and I want to wrap up just looking back and noticing we've covered a number of different areas, the causes of IBD and how diet may be related to IBD physiology. We've talked about specific diets and diet recommendations, and we've talked about the pros and cons of diet as either an alternative or a complement to conventional medical therapy. I think the take-home points are that diet strategies may be a useful adjunct to conventional therapy for moderate to severe IBD, might even be a reasonable primary therapy for mild inflammatory bowel disease. There are many theories about diet, but unfortunately data remains scarce. And I think it's very important to point out that dietary strategies are highly personalized. We can't recommend or endorse one specific diet for all IBD patients because one size does not fit all. And finally, the healthcare professionals can play a useful role in dietary strategies, both in optimizing the safety of these diets by monitoring for and making suggestions to prevent malnutrition, which is an intrinsic risk of inflammatory bowel disease, coordinating with conventional therapy to make sure that diets are safe and to optimize the efficacy and safety of medications, and then finally screening for asymptomatic complications that could be masked by a highly successful dietary strategy for symptom management. So at this time, we're going to stop and allow our listeners to write in some questions, and it looks like several already have over the course of the talk. Let's see. There's one here I saw earlier that I liked. Where's my mouse? So, actually, I think this is a good question for Shirley. Are you still there, Shirley?
Mm-hmm. Yes, I am.
So Kelly wrote that you touched on the role of vitamin D in anti-TNF medications. Can you elaborate further on this? Does more vitamin D help anti-TNF medications be more effective in some way?
Right. So this is actually just recently studied and published. You know, what we have right now is correlation data. There have been no studies sort of placing one group of patients on vitamin D supplements and another group of patients on no vitamin D supplements. So what the study did, and this came out of Boston, was they looked at vitamin D status of patients just before they started their anti-TNF therapy. So vitamin D levels were checked within 3 months of the patient starting on anti-TNF therapy, and they found that patients who had adequate vitamin D levels had actually a better response to anti-TNF therapy and were less likely to have anti-TNF failure if they had adequate vitamin D status when they started the medication. What we don't know, because this was just a correlation study, is that with those same patients who were deficient in vitamin D also have had a beneficial response had they been repleted in vitamin D prior to starting anti-TNF therapy, or if they had received supplements of vitamin D upon starting anti-TNF therapy.
So another question. Julia asked whether any of us, the three of us tonight, have ourselves either tried the specific carbohydrate lifestyle or prescribed this to our patients. And I can speak from my own experience that these are not diets that are taught in medical school. I've learned a lot more from my patients than they've learned from me. So I'm probably not a good example. But Trina, is this a major part of your practice?
Well, to answer, I have been on the SCD diet personally for over a year, and I found it really helpful. And then I personally altered that diet to be a little bit less radical, and I found that more comfortable and still successful. And I also have prescribed the SCD diet for patients, and sometimes I find it to be very helpful, and sometimes I find it to not do very much, which I think is consistent with what we're seeing. I'd have to go back and look at all those poll examples, but it seemed like many of the questions we asked was about 25 to 30% of patients found avoiding gluten helpful, 25 to 30% found avoiding dairy helpful. And so I would say that's true as well. For some patients, going on the SCD diet was a major hit, and other patients it was irrelevant.
So Joanne asked a really important question here. How do you know if you have stricturing versus non-stricturing Crohn's disease? And would diet control help to determine if one has it? I think this is a really critical question, given that two different dietary strategies that we approached, a low-fiber diet and then the SCD-type diet, are almost polar opposites to each other. So Shirley, can you talk a little bit about how clinically we go about defining stricturing Crohn's disease?
Yes. Stricturing Crohn's disease is a condition where it's typically made by diagnosis with a radiology study, so either a CT scan or an MRI scan or a barium study where they track how the contrast goes through your entire bowel. That's how the diagnosis is made, so it's something that's made between yourself and a physician. I wouldn't advocate using whether or not you respond to one diet over another to diagnose yourself with stricturing Crohn's disease.
And why not? Why not is that?
Well, I think that if you do have stricturing Crohn's disease, you definitely need to be involved with a physician. And the physician should be aware of that diagnosis as well. So it's something that you'd want to confirm, just because if you have strictures, then you may actually benefit from therapy to open up those strictures, either endoscopically or surgically, to alleviate your symptoms, more so than diet.
And what could be the worst case scenario if somebody were to just try an empiric fiber therapy to test to see if they have stricturing Crohn's disease?
Well, you certainly wouldn't want someone to develop an acute bowel obstruction. That would be the worst case scenario.
Okay, so another question from Sadiq. I hope I'm pronouncing that correctly. If you eliminate starch and wheat gluten, what would you recommend as a replacement or substitute? I'll throw this one at Trina.
I think that depends if you're trying to specifically follow the SCD diet. They usually use almond meal for baking things, if you're trying to use things to replace baked goods. The FODMAPs diet, you can still use rice and other grains like that for baked goods and those kinds of carbohydrates. But you can find carbohydrates in all your fruits and vegetables and beans and legumes anyways.
Oh, here's a good question. Kimberly asked whether we have any nutritional advice or guidance for women with inflammatory bowel disease. In her case, I guess her question is ulcerative colitis, who want to get pregnant. So is it a different situation? Is the nutrition picture different for a woman who is looking to get pregnant or is pregnant? I think it's Shirley's turn.
Yeah, well, I think nutritional status is very important, especially in the time of pregnancy. And, I think at this point it's actually very important to make sure that you're nutritionally replete at the time when you're planning to be pregnant. Most people advocate, at least taking a perinatal vitamin supplement that contains folic acid and DHA actually prior to even becoming pregnant, to make sure your stores are replete in that sense of micronutrients. The other thing that needs to be emphasized too is you want to make sure that your inflammatory bowel disease is in remission before you get pregnant, because ultimately active inflammation is the most determining factor of outcomes in pregnancy.
Here's one for Trina. So Margaret asked, I've read that some diets help Crohn's symptoms, but not ulcerative colitis. Margaret says she has ulcerative colitis and so would want diet advice that helps UC. Trina, as somebody who has lived with ulcerative colitis in the past, can you comment?
Well, I think right now we haven't differentiated the diets that we talked about, SCD, FODMAPs, and Paleo. We haven't differentiated between UC and Crohn's, and so they're all used for ulcerative colitis, which you have. The only diet that would be different is a low residue diet, which Shirley talked about for strictures in Crohn's, but otherwise the other diets apply to both diseases.
So Shirley, I know that you do a lot of work with celiac sprue, which is a very well-defined immune reaction to a very specific protein component of diet, the wheat gluten molecule. So Lise asked whether there's any correlation between food allergies and inflammatory bowel disease, which I'm going to draw the correlation myself that is it in any way similar to celiac sprue?
I think we do see some mimics of celiac disease in people with food allergies. I think the most common thing we see is patients who have a little small amount of inflammation, especially in the small bowel, that turns out not to be celiac disease, but actually turns out to be, say, for example, allergy to wheat-based protein. And there's other conditions like eosinophilic gastroenteritis, which is another inflammatory condition of the GI tract that sometimes responds to elimination of different dietary components, and typically the highly allergenic components, things like wheat, soy, nuts, dairy protein. So I would say right now for food allergies and IBD, there's not a specific relationship, but there is a relationship between food allergies and other inflammatory conditions of the GI tract. I hope that answers that question.
Shirley, here's another one that maybe you can answer. Tina, not Trina, Tina asked if there's data on the use of omega-3 fatty acids in inflammatory bowel disease.
Right. That's been studied as well, and I would say the results are very mixed. So there have been some studies looking at omega-3s with the idea that these are anti-inflammatory and components of an anti-inflammatory diet, and the results are all over the map. So you have some studies that show clear benefit, other studies that show no benefit, and other studies that show worse outcomes compared to placebo. So really the results are all over the map, and right now the party line is the evidence right now as it stands is insufficient to support that omega-3 intake is going to be used as therapy for IBD.
Well, Michael asked a question that is something that I think we kind of addressed probably subsequent to him asking this question, but I think it's an important enough concept that it's worth reiterating. He asks the simple question, probably in the midst of while we were discussing the various different diets, what diet is better for inflammatory bowel disease? So, Trina?
Do you mean what diet to choose between SCD
exactly.
and FODMAPs?
Of all those different diets we talked about, which one works best?
I think what works best is to combine the information from the diets and do a customized approach. So using foods that you know are a problem and avoiding those, and then I would say avoiding grains altogether, which I would take from SCD, and avoiding polyols, which I would take from FODMAPs, and avoiding dairy altogether, which in some way or another comes from both. So it's kind of a combination. That's what I would suggest. And, lifestyle plays a role, like I said a couple times, social and emotional impacts of diet. I've had patients who came in and said, you know, I have a child that's very picky, and I have a husband that's very picky, and I can't make 3 different dinners. Tell me one food to eliminate. And if I had to start somewhere, I'd say go off of gluten first, and then later try going off of dairy. So sometimes your lifestyle may impact what your ability is. But at the end of the day, my experience is that most IBD patients have a list of foods that they found can be either helpful or harmful, and it's worth embarking on that, even if you look at one food at a time and can't follow an entire diet.
So Paul acknowledged what I said earlier, saying that as you admit, medical school does not train you for dietary recommendations. Who's more qualified for giving this dietary advice to someone with a medical condition? So in other words, if you can't go to your doctor, who do you go to? Some clinics actually are able to provide the services of a nutritionist. This is kind of a contentious area because of medical billing. There are only a handful of conditions for which nutritionists can actually bill to get paid and not bankrupt their healthcare system in the outpatient setting.
I'll just interrupt. It's actually sort of specifically the registered dietitian qualification there.
Yeah, actually, you should talk about this, Shirley. You know a lot more than I do.
Well, I just think that in terms of people who are very experienced with nutrition counseling, I think the naturopathic physicians are very well trained. I think, Trina, you can certainly speak to that. And then on the allopathic side, registered dietitians are very well trained in dietary counseling as well. It involves a 4-year degree specifically in nutrition and dietary counseling, specific for different conditions, and then an internship after that. And many of the dietitians even have master's degrees in their field too.
I think
it's nice to find a GI-related person.
Yeah, definitely.
Yeah.
But not all nutritionists are necessarily going to focus on gastrointestinal conditions in general or specifically inflammatory bowel disease.
Exactly. So if you can find someone who has specific expertise in that area, it's definitely advantageous.
But definitely check with your insurance plan before going too far down that path, because a lot of insurance plans won't actually cover nutritional counseling, and it could get very expensive. But Trina, can you speak to the dietary training that was in your background and perhaps not in mine?
Well, diet's a fundamental part of our training. And I think most naturopaths use diet and lifestyle as one of the main components of treating any illness. Not all naturopaths have focused much on IBD, so they may have limited knowledge of things like SCD and FODMAP, so you'd want to find out in advance how much they work with those diets. But definitely diet counseling is an important part of our training.
Now, there's a couple of questions that have come in concerning the microbiome. And this is a CCFA talk, and the microbiome is certainly a major part of their research initiative. So I think it's fine to go ahead and entertain something that's a little bit off topic here. But let's see. Barbara asked if there are studies that show that fecal transplants help in ulcerative colitis. And I'm going to throw this to Shirley because I know that we've talked about this.
Yeah, we have talked about this. So right now we haven't had good evidence showing that fecal transplants help ulcerative colitis. There are studies ongoing right now, but right now it looks like no.
So actually one study that was conducted here in Seattle at the University of Washington, Dr. Tim Zisman had a trial of about 10 patients with ulcerative colitis, and unfortunately they didn't really see any positive benefit from fecal transplant in ulcerative colitis in that study. It's not been published yet, but there's another study similar to it that was just published last month. Again, completely negative and actually a little bit concerning in that nearly every patient developed a high fever shortly after the fecal transplant, suggesting that it might not only be ineffective but also potentially dangerous. Having said that, there's still a lot of enthusiasm for it, and I think there are going to be some studies forthcoming in Crohn's disease as well.
Right.
Now,
and I think the timing also makes a difference, too, and what other conditions people have. For example, if a patient with ulcerative colitis has had repeated bouts of C. diff, C. difficile, which is also a colon infection. There are good studies showing that fecal transplants help reduce the risk of recurrent C. diff. So if C. diff has been a troubling issue for you with ulcerative colitis, then a fecal transplant may be beneficial for that aspect of the inflammation.
And that's something that I've actually had personal experience with. I've had patients who have had concomitant ulcerative colitis and Clostridium difficile, and I can say that the fecal transplant worked great to get rid of their C. difficile, but
Exactly.
I've been struggling to control the ulcerative colitis ever since. So it's they're definitely two different diseases.
Yes.
And I would also caution that fecal transplant may have some hazards associated with it, particularly if you're immunosuppressed and susceptible to infection. So it's very important that if you pursue fecal transplant, you do it in a setting where the donor can be carefully screened for any potential infections. Otherwise, I think it's really a risky proposition. Now, probably a little bit safer and something related to the microbiome, Tina asked as to whether we can speak to the use of probiotics in inflammatory bowel disease. Do you want to address that, Trina?
Well, there's a lot of good research on probiotics and different probiotics for Crohn's and colitis as well. And one of the trials that we talked about today, they used SCD plus probiotics. To your point about the potential of infections, at least with a probiotic, we're not introducing problems with bad strains or things that can cause infection. And so, yeah, I think probiotics can be useful and very helpful, especially in decreasing frequency of bowel movements.
I know.
Yeah, I think that the area where we have the best evidence for it is actually with pouchitis and the use of VSL number 3 as a probiotic of choice in that condition.
Yeah, I think VSL3 has largely become standard of care for recurrent pouchitis. But even in native ulcerative colitis, I know of a study in which probiotics, I think it was again VSL3, was used in conjunction with an aminosalicylate, a mesalamine medication, and it was found to show some adjunctive benefits. So the patients who were on probiotic plus mesalamine did better than the patients who were on mesalamine by itself. So I think there actually is some good randomized data to demonstrate scientific proof that probiotics can be beneficial for both ulcerative colitis and pouchitis, or at least VSL3, who's funding most of these studies.
Right, and I think we can all have some sort of anecdotal evidence where it's been helpful in selected patients. I have to say in my own practice, in patients who use probiotics as primary therapy and it's working, I do monitor them quite carefully, which includes colonoscopy.
I'd also say, too, you know, they keep trying to do research studies on specific strains of probiotics, and I think that it turns out to be a little bit personal, and sometimes one patient will find a lactobacillus strain to be really helpful. Other patients might find that it didn't do anything at all, but they'll look to Saccharomyces, and Saccharo B can be really helpful. And I usually tell patients if they try one and it doesn't work, to stop spending money on it and rotate, try a different strain. And sometimes they have more success with a different strain. So I don't think I could advocate for a specific strain, aside from like what you're saying about VSL for pouchitis. Between Crohn's and colitis, it seems to be almost personalized.
So Terry asked a similar question about probiotics, but specifically asked about how one avoids dairy while using probiotics. I know a lot of probiotics are incorporated into dairy products. Is that much of a challenge, Trina, or is it pretty easy to find a dairy-free approach to probiotics?
Primarily, when they report that there's dairy, it's that the lactobacillus was grown on a dairy source. Mm-hmm. So the lactobacillus essentially has eaten it up. I don't think that it's a large enough volume of dairy to cause any problems for the majority of people. It would be trace amounts if it's in there at all.
So then the issue...
I don't think it's a concern.
So the dairy, the component of dairy that contributes to bad symptoms then would be the disaccharide, what is it, lactose, and not specifically a dairy allergen.
No, I think that dairy products can cause problems for patients in terms of the sugar, the lactose, or some of the proteins, the casein in the whey. But in terms of what you're going to find in the dietary supplement, the source of dairy is going to be limited to a trace amount or none if it's already been eaten by the bacteria itself. So if the product says on it that it contains a source of dairy, I don't think that for most people it's a concern.
So Ben asked, do particular foods actually cause inflammation or just affect symptoms? He states that he has inflammation that's mostly asymptomatic. Is it worth changing his diet if his symptoms are under control? So is there a role for diet in the asymptomatic patient, with the thought being that there may be some silent inflammation ongoing? Shirley, do you want to try and address that?
Yeah, so, I mean, I guess and the bottom line is we don't have any evidence for that right now. I mean, the best evidence that we would have is for using an elemental diet or tube feed type diet. And
it's a bit draconian for an asymptomatic patient.
Yeah, exactly. I mean, that's to have a tube placed for that purpose, I think, would be a little bit extreme. So then it would be just for symptom management, and you'd have to look for an alternative way to control the inflammation.
I think this kind of gets to...
The alternative is if someone tries a diet and then has follow-up, I mean, that would be the only way to really kind of hash that out.
Well, I think in an asymptomatic person, whether you're pursuing diet or medication, the big question is symptom control, should that be our primary endpoint, or are we looking for a so-called deep remission where we're eliminating any evidence of inflammation? Whether you're using diet or medication, I think it's a highly controversial area that is popularly debated at the CCFA's national meeting. Actually, it's happening next weekend in Florida.
I think also, I agree with you, Shirley, like there's no basis yet for making those kind of diet changes, but it's also hard to motivate a patient who's asymptomatic to make a radical diet change.
Exactly.
Okay, Kathleen's just told me that I'm only allowed to pick one more question, and there's about 50 of them here, so we better make it a good one. Okay, what about the role of other supplements, alpha lipoic acid, conjugated linoleic acid, and DHEA? This is from Wes. Can either of you answer that?
Do you want to take a stab first, Shirley, or me?
Yeah, I think that someone asked a question about glutamine as well. In that, you know, right now we actually don't have any evidence to support using those supplements. So as far as reducing inflammation, I think the exception would be for glutamine supplements in patients with short bowel syndrome. But there are a lot of issues that prevent it from being used sort of well, just because it's an unstable compound that requires frequent dosing. So right now I would say that it would be for symptomatic therapy only, not for treatment.
So actually with L-glutamine, there was a research study on Crohn's that actually showed a worsening. DHEA is a steroid hormone, and there actually is a really good research study on DHEA in patients with IBD, and it was in patients that failed to achieve remission with conventional medication, so they were a really tough patient population to treat. And there was a high rate of remission using DHEA. It was really high doses, 200 milligrams a day. But I have found DHEA to be probably one of the more powerful natural supplements that I use in my practice. I do always monitor lab levels as well. But I think it can be very effective, and I use it at a much lower dose than they did in the research study. That kind of dose, 200 milligrams, has a lot of side effects with it, but it's interesting to note that nobody dropped out of the trial because of side effects.
Well, I guess if the alternative is steroids, then, you know, you can pick your side effects.
Yeah.
Great. Well, thank you all so much for your participation. I will send out a link to the recording of this program early next week, and also slides that you can print out and answers to the rest of your questions that we didn't get a chance to answer here tonight. I'd like to thank our speakers who gave a lot of time prepping to give this information for you tonight. I hope that it was valuable for you and your family. When you leave the webinar, a short survey will pop up. We appreciate you taking a couple of minutes to give us your feedback on tonight's program. Thank you again, and I hope you will participate in future CCFA events. Good night, everyone.